On the behalf of this very good conference, the RADCON, at the outset, I thank the organizing committee here having given me this opportunity to be here and to present this topic. So already Amarnath covered widely about the MR spectroscopy. I will be focused on that only how MR spectroscopy in the intracranial cystic lesions. Okay, I'm going to cover only. So always we have diagnostic challenges. Okay, difficult to distinguish this cerebral abscess from necrotic. Always know it is, as Amarnath told just now. So it's sometimes difficult to have that infection versus tumors. Okay, of course we have to do other spectroscopy. Okay, so sometimes cystic lesions like metastatic lesions, and there are sometimes primary lesions also. Cystic high-grade gliomas can mimic infections. Okay. All the infections, sometime after treatment, sometime maybe diffusion restriction may not be there. So all diffusion restriction, you not expect to have that one, because once the liquefaction starts, you may not get the high viscous lesions. So these are all challenges occurs. So this need another modality by MR spectroscopy. So tuberculomas, cerebral abscess, parasitic cyst. Okay, post diagnostic problem throughout the Southeast Asia, particularly India. Okay, hyperintensity with the restricted diffusions is diagnostic, but not pathognomic. Okay, sometimes pyogenic abscess diffusion can occur. So the learning objective today that to determine how MR spectroscopy can help to differentiate tumor from infective lesions such as abscess, and to differentiate tuberculous abscess from pyogenic abscess. He already talked about the previous speaker, that Amarnath. Okay, how to differentiate pyogenic abscess with the parasitic cyst by using MR spectroscopy. So this is a patient, just to give a 22 years old young patients, male present with a seizure. Okay, so these are lesions where, okay, this is a patient having that well-rounded small nodular lesions, which is appears bright in the T1. Okay, the peripheral rim is bright and dark in T2. A similar case we have shown Dr. Amarnath. These are like edemas there, and there is no areas, unfortunately there is no diffusion restrictions. And look at the lesions. Okay, easily anybody can mistaken as a granulomatous lesions. Okay, so we did MR spectroscopy. MR spectroscopy says gross elevation of the choline creatinine ratio. This choline creatinine ratio is around maybe 4, near 3.93. So lesions show suspicious of, there is no lactate peak or nothing. Okay, so it is MR spectroscopy disclose the lesion like it is a neoplastic process. So it is confirmed it is actually grade 2 astrocytomas. Okay, grade 2 astrocytoma, because this is normal spectrum. You can say that this is a normal spectrum. The abnormal spectrum is choline creatinine ratio. This is a reverse angle. The choline gross elevated. This is one of the clue for some time. MR spectroscopy may be very valued if you involve within the routine imaging studies. So always it is not always. Sometimes can give a very important in the armamentarium of your imaging studies. Another case. This is a 62 years old, well-defined cystic areas with a small suspicious lesion in the thick wall, and look like a lesion like like granulomatous lesions, and a lot of edemas there. And there is something, it is eccentric nodules there in the gado, and lesion is the peripheral rim enhancement. It is look like similar like a cystic lesion of granulomas. Okay, and this is a patient having a slurring speech because of that areas. And MR spectroscopy was done. MR spectroscopy again, it will be again choline creatinine ratios, and lactate peak is there 144 ppm, 144 T. Okay, this is almost confirmed. This it is not a choline creatinine ratios around 3, so it is confirming it is not in the not infective stage. It look like a neoplastic process because the grade are slightly more than 2.5 to 3. So suspicious for the neoplastic process. And this is we did just know the first talk our Sayani said about you should be clinical radiologist. This patient went back and the X-ray test shows there is a lesion. It was lesions missed in the previous investigation, the X-ray test shows large nodular mass lesions and confirm this metastatic lesion. So this confirm this metastatic lesion from primary lung carcinomas. Yet another case, 57 years male, known case of carcinoma nasopharynx, present with headache, and there's here the lesion is a large lobulated peripheral thick peripheral enhancing lesion in the left and the temporal region. There are subtle lesions also seen in the right side as well. Okay, and a patient had nasopharyngeal carcinomas operated and treated. Okay, and we did a mass spectroscopy. There is no choline creatinine relation, only lipid elevations. So along the pathway, this is exactly along the pathway, this lesion actually there in the both temporal lobe. So confirm this is only, it is not a neoplastic process, it is a radiation process, radiation-induced changes. So after 3 months, okay, the lesions, another lesion also on the seen in the right side. Okay, so confirming only that the lipid elevations, there is no choline creatinine. So confirm this is a it is a post-radiation changes only. So post-radiation changes can mimic a tumor. If you do a spectroscopy easier, or maybe you can, sometimes the pattern also give a diagnosis, like, the peripheral thick wall, pattern, this pattern maybe can have that appearance in radiation necrosis, like, the changes. So yet another patient, the 34 years female, disorientation, weakness, right off of the body, large lobulated lesions and peripheral rim enhancement, and there are lesions, it is not homogeneous enhancement peripheral, there is something subtle and some areas actually like almost. Another lesion in the left temporal region, left frontal and right frontal region. So it is look like a neoplastic process, and patient having that is only the right half of the body. And this spectroscopy was performed. MR spectroscopy shows there is a myoinositol peak in this short T and the lactate peak. And if you see carefully, there are something areas actually, it is not complete enhancement, the rim enhancement. The rim enhancement is something, it is deficient on in the one lateral aspect. So confirming something, it may be something clue, kind of, it's not a neoplastic process. So this is a MR spectroscopy, myoinositol, lactate peak, and there is not much of choline. Na is grossly reduced. So this pointing favor for a tumificative demelting process. So this patient and follow-up, and this is the lesion become regressed. Okay, after that 6 to 9 months. So okay, myoinositol peak is increasing. So how do neoplastic and non-neoplastic lesions? We have done around 91 cases. We did. There's statistically, it is significant. The choline creatinine ratios more than about 3.5 to 3.8 give a clue for making diagnosis towards a neoplastic process versus to differentiate the infective process. Okay. For limitation of MR spectroscopy, in sometimes fulminating to demelting process, high choline sometimes can occur because of the reactive changes, but the most important thing, Na will be reduced. Okay, and presence of lactate give a clue, make a diagnosis to differentiate tumificative demyelination from neoplastic process. A distinguishing metastasis from high-grade neoplasm on the spectroscopy is sometimes unreliable, so we have to correlate with the imaging finding as well. Other diffusions, other spectroscopy, other than spectroscopy, images like a perfusion images, you need important. In GBM, okay, hemorrhage often with that cystic nature, often challenging in particularly MR spectroscopy. Coming to the infective process, cerebral abscess from the necrotic tumor, sometimes difficult to have. That in those situations, MR spectroscopy very valued informations. Elevation of the choline and absence of amino acids and acetate and succinate favor for neoplasm. Okay, the elevation of the choline and absence of amino acids and acetate and succinate favor neoplasm, and the presence of alanine, acetate, pyruvate, succinate more of favor for diagnosis abscess. Detection of amino acid on the 0.9 ppm as an inverted peak at as a 144 or 136 TE is promising tool for differentiating bacterial abscess from cystic brain tumors. Example, here the typical case of brain abscess. Okay, there is a diffusion restriction and very thick wall, and if you do that MR spectroscopy, leucine, isoleucine, amino acid in 0.9 to 1.3, with a lactate peak and very characteristic of pyogenic abscess. And pyogenic abscess, again, it can be differentiated, it can be depends on the anaerobic and anaerobic organism. Increased lactate, acetate, and succinate originate from the enhanced glycolysis and fermentation of the infected microorganism. The amino acids valine and leucines are end product of the proteolysis by enzyme released by neutrophil in the pus, and acetate productions are more favorable for those. There's a succinate, they lead to succinate production in the anaerobic organism. So MRIs can be very useful to make an anaerobic versus aerobic organism, as by this article, and as well as R.K. Gupta, Professor R.K. Gupta have done wonderful studies in HGB Chandigarh. Anaerobic bacteria tend to cause elevated lactate and succinate peak. Absence of acetate and succinate signal are more likely to obligate aerobic and facultative anaerobic organism. Aerobic abscess can be differentiated from GBM. Absence of elevated choline peak, rim enhancing wall, statistically significant difference compared to the normal brain parenchyma. So here example, this is a patient having well-defined rounded lesion in the cerebellar parenchyma, thick wall, and you can see that acetate and succinate peaks and acetate peak is there. And as well as amino acids, the metabolism in the amino acid 0.9 and acetate 1.9 and succinate. Sometimes you can get alanine peak also sometimes. So this can be pyogenic anaerobic organism. On the other hand, you can get lesion having thick wall, enhancing lesions, and that very bright and dark areas, signal intense areas. Okay, this can be tuberculosis abscess. Only lipid peak only is there. Only lipid peak. So amino acids and lactate succinate will be more of favor of pyogenic, whereas tuberculosis abscess only lipid. Here the lobulated cystic lesions and cystic lesion with a thick wall. Okay, and lesion become very homogeneous enhancement or peripheral rim enhancement. This is a 55 years old patient with a headache, and MR spectroscopy showed alanine, more important in pyruvate, okay, and lactate peak and amino acids peak. Okay, these are all combination of all the three confirming this intracranial or hydrated cyst formation. Okay, with this pyruvate is one of the very parasitic etiology. Okay, here is another patient. This patient had the first MRI and cystic lesion in the left temporal lobe, and there's peripheral thoughts of enhancement. And this again this MR spectroscopy, there is a pyruvate enhancement, pyruvate peak, consistent with there is a cysticercosis, racemose type of neurocysticercosis. Resonance at 2.4 pyruvate, the predominant metabolite in the cystoidal cyst, infesting human CNS infection. Pyruvate is maybe a marker of parasitic etiology, perhaps that viability such intracranial cyst. In this same patient, after albendazole, the lesion become completely solved, confirming this is a patient having this patient having that albendazole treatment is become all right. Okay, so accuracy by versus benign versus malignant lesion. Okay, very accurately make a ROC curve with a 94% sensitivity, and so malignant lesions and benign lesion can be easily made out by MR spectroscopy with a true positive or 90% in our studies, and specificity about 97%, and positive predictive value about 97%, and negative predictive value around 92% in the particular studies. So the take-home message: this is a cystic tumor choline creatinine ratios more than 2.5. It is a cutoff value. It is more of cystic tumor, and the pyogenic abscess amino acids and 0.9 at 0.9, alanine 1.4, and acetate 1.9 ppm, and pyruvate 2.3 ppm, succinate at 2.4 ppm, and option choline creatinine suggests of pyogenic abscess, and tuberculosis abscess will be high, only lipid lactate peak, and options of amino acid and succinate peak. Okay, to conclude, MR imaging, when combined with the routine conventional imaging, particularly diffusions and other sequences, MR provide valuable information as potential validate the treatment of strategy. Thank you very much for your attention.
Thank you, sir, for excellent presentation.